Good morning, everyone. Thank you very much for joining us. I'll just give people a couple of minutes to join the webinar and then we'll make a start. Yeah, I can see that there's still people just coming in, so I'll just give people another minute or so and then we'll make a start just shortly. Okay, the numbers seem to have slowed down, so I'll just stop sharing this screen. So good morning, everyone, and welcome to today's virtual information webinar on Charcot-Marie-Tooth Disease. I'm Jackie Monroe and I'm Head of Regional Support Outreach and Information at Muscular Dystrophy UK. I'm chairing today's session along with my colleague Dr. John Copier, who's Muscular Dystrophy UK's Research Manager. If you have any questions about the session content today, you're welcome to get in touch with either of us directly. So we're really delighted you could join us for what promises to be an informative and valuable session. We have a very packed agenda this morning with a fantastic array of speakers. We're going to split the session into two parts, beginning with a discussion on research and a chance to ask any questions that you might have on that topic. We'll then move on to discuss living with Charcot-Marie-Tooth disease, where we'll have a general discussion and a focus on answering your questions. So throughout the seminar, please feel free to submit questions using the Q&A function at the bottom of your screen. We'll cover as many as we can, including those that have been submitted in advance. Unfortunately, we won't be able to invite people to speak directly, but we'll try to make sure that the questions are brought into discussion during the seminar. If we're unable to answer any of your questions during the session, we'll aim to follow up with you afterwards and we'll share additional information on our website as well. So while we'll do our best to cover as much as possible today, some specific or personal questions might be better addressed by your clinical team or your neuromuscular specialist. So this session's intended to provide general information and it doesn't replace individual medical advice. So just a reminder that MD UK's helpline is available to support anyone who is affected by muscle wasting and weakening conditions. So whether you have questions, you need advice or you're looking for support, we're here to help. So you can reach us on 0800 652 6352 or via email, which is info@musculardystrophyuk.org. So today's seminar has been recorded and the video will be made available on our YouTube channel in the coming days. We'd also like to thank our sponsor today, PTC Therapeutics, for supporting our virtual webinar. While they've generously sponsored this event, they have no control over its content or influence on its proceedings. So as I mentioned, John is chairing with me today and I'll be chairing the first part of today's session. And to start us off this morning, John will introduce our first speaker.
Thanks, Jackie. Welcome everyone to this research segment of today's webinar. We have two great speakers for you today. The first is Professor Mary Reilly. Mary is the Professor of Neurology and the head of the Division of Clinical Neurology at Queen's Square Institute of Neurology, which is a bit of University College London. Mary's pioneered research into peripheral neuropathies, and her research has identified genes that are involved in several forms of Charcot-Marie-Tooth, and she's very active in clinical trials. She's the co-director of the International Centre of Genomic Medicine in Neuromuscular Diseases, and she's a past president of the Association of British Neurologists. Earlier this year, Mary received an honorary MBE for her services to medicine and in recognition of her outstanding contributions to neurology. So it's my very great pleasure to welcome Mary. Please, when you're ready, if you'd like to share your slides and begin your talk.
Thank you very much. Can you see my slides? Yeah, Thank you. Well, thank you very much, John. I'm very pleased to be here and to give this talk. I'm going to do a general update on CMT research, just to give a flavour of what's going on. Luckily, there's so much going on that it is impossible to cover it in a short talk. So that is a very nice position to be in. These are some of my disclosures. So just to remind us what we're dealing with very briefly, this is a disease described by 3 men in 1886, and it is a hereditary motor and sensory neuropathy. So that means it affects the nerves in the arms and legs, both the motor nerves that start in the spinal cord and go to the muscle, and the sensory nerves that conduct sensory input, that is sensation, from the skin to the spinal cord. That's why it's called a motor and sensory neuropathy. So it is a genetic condition, that is, abnormalities in our DNA give rise to the disease, and therefore there are many different ways it can be inherited. And I won't dwell on these today because they're individualized for particular genes. Now, it can be a little confusing for patients because the classification is confusing for us because people keep changing it. But briefly, a nerve has got a central bit of the nerve called an axon, and it's surrounded by conductive material called myelin. And if there's a problem with the myelin, it's called demyelination, and a problem with the axon, it's called axonal. And in CMT, we refer to the demyelinating form as CMT1 and the axonal forms as CMT2. Now, I wish it was that simple, but people have added in other numbers to account for the underlying inheritance, and there are letters added. And the simple way of remembering this is if you have CMT1 or CMT2, the letter after it refers to the gene. For instance, CMT1A is PMP22, CMT2A is mitofusion. And I nowadays tend to use the name of the gene rather than the name of the type of CMT, because with some of them, we've got the second version of the alphabet, or an SS and a ZZ, so it's got even more confusing. So when I see patients in clinic, there are usually two main queries. What is my diagnosis? That is, what is my type of CMT? And is there a treatment? There are many other things, and we deal with those later, but they are the two issues. Now, from the diagnosis point of view, things have been revolutionized by advances in technology. And this is a paper from my group last year. And of almost 1,700 patients, we get a genetic diagnosis in 77%. And that's the kind of percentage you should expect to. So if you go and see someone, there should be a 3/4 of a chance you get a genetic diagnosis. Now, to break it down, we're much better for CMT1, where we have a 97% diagnostic rate, whereas for CMT2, we're probably still at 50%. That's still more complex and more difficult, but it is constantly increasing with new genes every year. Now, for the second bit, if we look at the treatments, and as I said, we've done very well with the genes, we've over 130 genes, but translating the finding of a gene to a treatment, we at the moment have no specific treatments for CMT. And I hope this year will be the very last year I'll show this slide, because things are advancing hugely fastly. And this is a review from earlier this year showing the number of compounds, mostly in preclinical, but some of them now in clinical trials. And just to break this down very briefly, with any genetic condition, you start with your DNA. The DNA gets transcribed into one strand called messenger RNA, and then gets translated into a protein. And every form of CMT is due to an abnormality in one or the other protein. So that is what causes it. So when we think of therapies, there are 3 different ways we can think of it. The first is what I call pathogenesis therapy. And that's where you find out what that particular protein does wrong and try to fix it. And I'm going to give you an example of that that's actually in clinical trial. And this is a gene that was only found in 2020 called SORD. And many people have heard of it because of the clinical trial. And that was found in a big international collaboration. And the lead author was Andrea Cortese, who was doing a postdoctoral with me at the time, and now is a colleague here in Queen Square. And this causes a form of CMT that has mainly motor, so it's more motor than sensory, and the average age of onset is in the 2nd decade. But it's a very slowly progressive form of CMT. And the gene causes an enzyme called sorbitol dehydrogenase to become inactive. So it's an autosomal recessive disease where you need 2 copies of the abnormal gene. And when it becomes inactive, there's a buildup of this chemical called sorbitol, a massive buildup to about 100 times normal, and that damages the nerves. Now, luckily, there was a drug which had been developed for a different disease available called an aldose reductase inhibitor, which can inhibit this gene further up the pathway and get rid of the excess sorbitol. So this was taken to a clinical trial in 22, so only 2 years after the gene was found. And this drug is called govorestat. And the trial was planned to be over 24 months, but at 12 months, because there was a reduction in the sorbitol and the patient outcome measure, not the clinical measures, but how they felt had improved, they decided to stop the 12-month trial and put everyone on the drug. And they're applying in the US for what's called accelerated approval. We did the MRI fat fraction, what I'll come back to, and for those people that completed the 24-month study, which were small numbers, we did show in that small number a marked reduction in the progression of fat infiltration. So this is encouraging, but the numbers are small. The company have now planned a further confirmatory trial, which will start in the next month, and there will be UK site in this, we'll be doing it as well. And this will be over 36 months to see, does that initial trial look like it'll be positive? So it is likely this may become the first treatment license for CMT. If it gets the accelerated approval, that could happen very shortly in the US and then subsequently in other countries if the second trial. I'm just going to mention this trial very briefly because it is one we are doing in the UK, and it's another pathogenesis treatment. It's a very rare form of CMT called hereditary sensory neuropathy type 1, and the treatment is serine, and I won't go into this, but to say to those people that have been involved in it, we've now finished the trial in September 2025 and are currently analysing the data. But moving back to the types of ways we can treat patients, well, another very attractive way is pathway therapy. Say we had something good that could treat multiple forms of CMT, and that's always been very attractive because it's 130 genes. And there are multiple pathways being explored. One is in phase 1 and one is still in the preclinical, but there is one pathway that's now in trial, and this is called a chloride inhibitor. This is based on looking at the neuromuscular junction, that is the junction between the nerve and the muscle. And it has been shown, both studying it in humans by electrophysiology and in animal models, that if you inhibit the chloride channel, that it can enhance muscle function. And this is now finished a very small trial, and that trial is being analysed with the plans of going to a bigger phase 3 trial, which, if this does go ahead, should start later this year or early next year. That is encouraging because it may be not quite a symptomatic treatment, because it's more than that. It enhances muscle function, and that could be applicable across multiple forms of CMT. But the game changer in genetics has been gene therapies. That is trying to fix the DNA or the RNA. And at the DNA level, you can use ways of editing that is permanently changing the DNA, or you can replace genes, and this is particularly applicable to the rare autosomal recessive forms of T, where the problem is a loss of function. So you can package the gene in a virus, an inactivated virus, a bit like a messenger RNA vaccines, and deliver it to the cells. And then you have other ways of editing the RNA, but that is something that would be not permanent, would need to be given repeatedly, called antisense or silencing RNA. And these can all act across multiple forms of genetic diseases, although they're modified to be specific to one disease. But this has been dramatic in terms of other diseases like SMA and Duchenne's muscular dystrophy. Now, this is what's happening in CMT, and this is up to date from late last year. This is an amazing number of preclinical studies going on, and these two are the ones that have been taken to humans. This one is a really rare form of CMT called SMARD1, and it is undergoing an trial in the US at the moment. And this other rare form of CMT, a devastating form that causes early onset disease, there's a phase 1 trial about to start on the west coast of the US. But most patients want to know about CMT1A, since it is the commonest form of CMT, accounting for about 55% of patients in the UK. Now, CMT1A, of course, is the classic form of CMT, where you have a duplication of chromosome 17, such that you get 3 copies of PMP22. Patients usually present in the first or second decade, and it's a slowly progressive sensory and motor neuropathy, with a high morbidity in that patients have a lot of problems with their feet and sometimes have had to have multiple surgeries. So we know that normal people that do not have AV CMT have 2 copies of PMP22, one from their mom and one from the dad. But when you have CMT1A, you have 3 copies of CMT. So what you really want to do is reduce the amount by 33%. And the type of therapies that are absolutely ideal for this are antisense and siRNA. They can just silence the production by about 30%. And the original preclinical animal study was done in 2018, and it showed dramatic response to doing this, both looking clinically and looking at the expression. This meant, luckily for CMT, lots of companies got immediately interested in developing it. And these are just some of the companies. And the lead company was a company called DTX Pharma, who developed an siRNA. And this was bought by Novartis 2 years ago. And the really exciting news is, as of about 2 weeks ago, the first in-man study has started. Now, the first site has opened in Canada, but keep an eye on this space in terms of a UK site in the next couple of months. Now, this is a phase 1 study. That means it's not looking to see, will it work? It's looking at safety, tolerability, and pharmacokinetics. That is, what doses are needed. And this will be in adults first, aged 18 to 16, and this has started. Now, if this is successful, it will then go into a large international study of gene silencing in CMT1A, and that is an extremely exciting development. In the UK and in other countries, there are a couple of big challenges that I just mentioned briefly. Across the world, one of the challenges is doing clinical trials in very rare diseases and having outcome measures sensitive enough to measure change in 1 to 2 years. Patients will know they feel they've changed, but doctors can usually not measure change for 4 or 5 years. So we've developed the most sensitive way of measuring change, which is the fat accumulation in your muscle as your nerves don't work properly. And this is just showing you that as your CMT becomes more severe, you get more fat infiltration. And we've now shown you can measure this accurately in adults with CMT1A. If we go to the feet, we can measure it accurately in children with CMT1A, and we can measure it in CMT-X1, 1B, and 2A. So across all forms of CMT that are length dependent, worse than feet first, we can measure this, and this is exciting. The other problem in the UK is a lack of centres that are ready to do clinical trials, that know what patients they have, and that have the expertise to do it. And a very exciting development in the UK is this grant called Transform CMT. That stands for Trial Readiness Charcot-Marie-Tooth Disease. And I'm delighted to say that Muscular Dystrophy UK have funded a 4-year grant, which started in August 2025. And we lead the grant in UCL. And this grant is allowing us to really take this AI, the protocol for the MRI, that step further. And we're calling it a AAA protocol, Advanced AI Accelerated Protocol. And this will be reduced to 30 minutes and completely automated. We've partially automated already so that it can be easily done in any scanner, that is Siemens, Philips, or GE, anywhere. And the second really important part of this study is to look at the CMT landscape. Who are the patients? Where are they? What genotypes do they have? And to set up geographically dispersed CMT trial-ready centres. Now, this is for adults initially, as the trials will be done in adults initially for most forms of CMT, although not all forms. So these are the centres. So we lead it in London, and we are setting up centres in Oxford, Cambridge, Manchester, Liverpool, Newcastle, and Glasgow. Now, the first thing I know I'm going to get questions about, and I've had them, what about Wales? What about Scotland? What about the Midlands? So we canvassed all over, and we were able to set up in centres who had some expertise available already in peripheral neuropathy. Wales at the moment in Northern Ireland weren't able to participate, but I hope they will if we get a second version of this. And also in the Midlands and in the Southwest, it would be nice to have centres in due course. But for the first go at this, it's setting up 7 centres, 6 outside London. And I think that will make a huge difference to patients, because certainly with our SENSE trial, one of the commonest reasons people didn't want to partake was of the travel to London. Now, when you tell people in the US that travel in the UK is a problem for patients, they always think, well, how could it be? It's a little country. But travel is difficult for patients who are very disabled and committing to long days in clinical trials. So having dispersed centres, I think, will be extremely important. So just to finish by acknowledging the inherited neuropathy group in Queen Square, huge number of people that do a lot of work across 3 areas really: gene identification, natural history studies, and clinical trials. And of course, to acknowledge all of our funders, and particularly Muscular Dystrophy UK, whom have been very generous and I think really innovative in trying to help set up trial centres across the UK. Thank you very much.
Thank you, Mary. That was a really great talk. I can't see any questions in the chat, so maybe that allows me to indulge myself in some questions of my own. Starting with the MRI technology, obviously this is a technology that's allowing you to see smaller changes over a shorter period of time. So that's great for clinical trials. Do you see any diagnostic application for that technology?
Sure. So first of all, to go to the first part of that, so we've been working for over 20 years at developing clinical outcome measures, and we've developed them for infants, for children, for adults, both ones impairment and ones are functional. And they do measure change and pick it up over 2 years, 3 years, 4 years, 5 years, but not enough change over the 2 years that you would want in a clinical trial. So the reason we developed it was to get a marker that could pick it up earlier. And we've now shown that change in 1 year in MRI predicts change over 4 years in the clinical measures. Now, we've a range of other plasma biomarkers that are blood tests that we're also exploring. Again, some of these show change, but we've yet to show they show change over 2 years. Now, diagnostically, in muscle diseases, the pattern of MRI can be very helpful. In nerve diseases, some of them it's helpful, and I've used it to validate we found a change in a gene. It's been helpful in some rare forms. But by and large, it shows the pattern, but not specific patterns for specific diseases, because many forms of CMT, it is length dependent. The further you go down the legs, the worse the changes. But we now know you can tell nerve muscle fat fraction changes from ones due to myopathy. So in nerves, you get these islands of muscle changes, and so it can be helpful in that. In practice, I do use MRI. I use it, increasingly use it to look at progression. But in real life practice, it's a qualitative study. So we'd look to see what is the amount of fat. The quantitative that we measured accurately is something that during these 4 years we want to introduce to NHS practice. And we have a separately funded program doing that. Now, the way to do that, of course, is to get it so it's easily implemented by the companies so that when people buy MRI scanners, which one does, that they can just press a button and get the fat fraction. So I have absolutely no doubt this will be useful in monitoring disease. In CMT, not as useful in diagnosis unless there's a diagnostic uncertainty, is it muscle or nerve? But in certain rare forms, it is useful. So it has use and it will be increasingly used. I think we've shown in an international study that it's equally good in all different scanners. And people say, oh, an MRI, that's very expensive. Everyone's got an MRI now. Every single, every hospital has an MRI. So technically getting it done. For children, people worry, will children stay still? And we've worked very carefully with Great Ormond Street. And we do it in children above the age of 5, because below the age of 5, keeping children still is not really an option without a general anaesthetic. But we can do this in most children over the age of 5 without a general anaesthetic. But one of the reasons for shortening the protocol is to make that even easier. People do ask about ultrasound because that's much easier to do. You don't need to put someone in a scanner. It can be useful to look at nerves, but to date has not been shown to be sensitive to change over a year or two. My instinct is it won't be sensitive to change, but it is useful at looking at the muscle and to looking at the nerves. And in children, that's particularly attractive. So in the long term, what I'd love, of course, is a blood biomarker, because that would be easier for adults and children and hopefully would change quicker. And with our ultrasensitive ways, we have multiple ones in development and currently have about 10 that we're looking in a longitudinal study. But we don't know whether they'll be sensitive enough because most forms of CMT progress relatively slowly. So finding something that changes quickly is a huge challenge, and convincing companies, I'm very pleased to say that Applied Therapeutics have agreed to do a 3-year trial for the confirmatory study, because if you want to look at a clinical outcome measure, we don't want patients being wasted with their time. We don't want patients doing clinical trials, and we could talk for hours, which I won't, on the wasted clinical trials that have used clinical outcome measures that were never going to show a result. That's been pushed by FDA, EMA, MHRA is being pushed by the licensors, but it's up to us to prove to them that the other measures are better. So they will use the measures that are proven in other diseases until we show them there's something better. I think we should be all encouraged, though, with motor neuron disease, where a gene therapy has been licensed based on a blood biomarker rather than the clinical outcome. So it is changing the landscape where these licensors may actually allow us to do trials in smaller numbers of patients, looking at biomarkers without having to put hundreds and hundreds of patients through very long protocols. A long answer.
A good answer. Thank you, Mary. And I think you probably answered the other question that I've got here, but I will just check. I mean, my instinct here is, so the question is, I have a 5-year-old with a rare axonal form of CMT. Would it be worth requesting the fat fraction MRI of his foot? His doctors haven't mentioned it. We're based in the Republic of Ireland. I mean, my instinct based on your answer is probably not at this point, but if you'd like to reflect on that.
Yeah. So the answer is you won't get it in the Republic of Ireland, but nor will you get it in the UK. It's done, we did it as a research tool. So what you have to have for that is special coils for the foot. And in 3 of the 6 centres we're setting out outside London, that is Glasgow, Oxford and Cambridge, they will have the capacity to do this. But we have to set it up first of all. This takes, technically doing the feet is a little bit more difficult, not difficult to do, but it's not available anywhere else at the moment. To be honest though, for an ordinary diagnosis and monitoring, you know, the clinical assessment is still extremely useful. Neurophysiology is good at the diagnosis, not so good at showing change quickly over time, although it does over longer periods. So I don't think there's any advantage to a 5-year-old having an MRI of the foot. If they have a diagnosis clinically and genetically, that won't change that. And the monitoring at the moment, there is some good clinical tools to monitor over periods of children outside a clinical trial. I mean, the therapists are particularly good, you know, because in children, it's very important to look at the feet, look at any foot deformity, to intervene as early as possible and to try to prevent foot deformities progressing to needing surgery. But if they need surgery, to do it at the right time by the right people, which of course is a whole other discussion as to what is the right surgery, when and where.
Thank you. I think you've probably also covered the other question we have here about use of fatty muscles to help identify CMT. So perhaps we'll move on there.
Yeah, I mean, I think occasionally, I think there's, you know, it's very occasionally diagnostically where it can be difficult for people to know if there's definitely neuropathy. And one of the questions we're addressing, and it looks like it will be, that fat fraction is more sensitive than early EMG, that basically it may be more sensitive in the axonal forms. In the demyelinating forms, the electrophysiology is easier to do, but it may be that fat fraction is more sensitive because sometimes you have a child or a relative and you know, you'll see the pediatricians, and I know there's a pediatrician, I'm very careful here saying, they're just, you know, they're just not quite right, but is this normal for age or is this abnormal? And children don't always want neurophysiology, and it isn't always sensitive enough at very early stages. Now, this is irrelevant to a certain extent when there's no treatments. But there's no question from our studies, and I hope from looking at the fat pictures I've shown you, that we've got to move to eventually treating really early. So everything we're doing in adults, we will want to translate back to children. So really early diagnosis has become really important in genetic conditions once you have therapies. So I think that question will become a much different question once we have therapies in place. Because having the gene defect isn't enough to say you have the disease. We have predictions of how likely you're to get the disease, but not every genetic defect means you'll definitely get the disease. And also, even with the same gene, the severity and age of onset of the disease can vary within families and between families.
Thank you. We have a question, a request to supply some web links, which I think we're happy to work on. We have people's emails addresses, so we'll get back to you by email after this. Sorry, one other question. Let me just read this one. I think the question regarding referrals, if we could just put that off to the Living Well session, because I think it will work better in there. So perhaps just one last question, Mary, because you mentioned CRISPR among those range of possible techniques for treatment going to the future. So we've seen quite a lot on gene therapy, quite a lot on antisense oligonucleotide therapy across a range of different rare diseases. CRISPR is perhaps a little less well known. Perhaps you can speculate on the likely utility of CRISPR in the near future, and particularly for CMT.
Yeah. So first of all, it is being used for another inherited neuropathy in a clinical trial. So that is the first in human use of CRISPR, that is TTR amyloid. So basically, CRISPR is a way of going in and permanently editing the DNA. Now, I say permanently very purposefully, because the word permanent means safety has to be absolutely 100% guaranteed. So if you're doing something permanently, you can't reverse it, whereas antisense and siRNA, you can. And therefore, there's a huge amount of work that would have to be done to make sure there was no off-target effects. So something you didn't predict happening. So in the first trial has just been published in September 2025 of the use of CRISPR-Cas9 to permanently edit another gene, TTR, in the liver. And it's a safety trial, 36 patients in an open label study, and it was fantastic. And the outcome for the clinical measures were excellent. But I know there has been a safety concern since then, and at the moment the trial is on hold about the liver test that may be overcome. So I think the safety barrier is huge in that. I think it will come, whether it's CRISPR or a different form, permanent editing will come. You know, we think we know the whole genome. We probably don't know the whole genome yet and predict an off target. So I would say in the TTR field, which is ahead of us, there is now in trial an siRNA that only needs to be given subcutaneously every 6 months. So one of the questions is, if you've something reversible that works just as well versus something permanent, you really need to have the safety of the permanent versus the safety of the one that you can reverse in place. I do think, though, that, you know, thinking about viral delivered gene therapies, if there was a way of gene editing being able to correct these really severe early onset forms of CMT, particularly the axonal, that didn't require giving a viral directed gene therapy, and that's the look into the future, I can see a huge role for that. So I've no doubt it will come. I've no doubt it will come for CMT, but I think there's an understandable big safety barrier to cover yet. But it's used for hematologic conditions where they take the cells out of the body, edit them and put them back in. But TTR amyloid is the only human condition to date that has had a trial very successfully. That's easier to treat, though, because you have to target the liver, whereas most of our diseases, we're trying to avoid the liver. So it's a little bit of a conundrum there. But it is coming, and it is only one of a number. It's a huge research tool at the moment. It means it's very easy for us, relatively speaking, to be able to manipulate things in the research environment by editing them. But I've no doubt it will come. I mean, I think we always say this, but I really think we are at a sea change at the moment in gene therapies. You know, it is not only will clinicians and patients get used to them, but we as clinicians have to start thinking totally differently. So we're dealing with patients that have the natural history on therapies. I mean, SMA is a totally different game than it was 5 years ago. And we have to learn to monitor diseases, to monitor disease complications and complications of treatment. So, you know, that's a totally different way of looking at things. And we don't know what the future will bring in this, but it is a very exciting time for patients. But I'm very careful, having got myself badly burnt since the Serine trial. When I said to a patient many years ago, we would have a trial within 5 years, he appeared in my clinic 5 years later and we hadn't started the trial. So this time I've said very carefully today what's in trial, what's starting in the next few months, and with the gene editing, I'm not saying when, but it will be some years, I suspect, before it's in trial in CMT in patients.
Fantastic answer. Thank you so much. Thank you for your time today. I think you're going to stay on for the Living Well session. I feel that time is pressing on, so I'm going to move on to our next speaker. So thanks once again, Professor Mary Reilly. And I would like to introduce Dr. Lydia Jestice. Of course, there is a lot of work in that kind of circle that Mary put up earlier, which underpins our understanding of conditions and kind of is at the beginning of that process of developing treatments, and this is definitely an area in which Lydia works. So Lydia is a postdoctoral research assistant at Sheffield University. She first developed an interest in neuroscience during her degree at the University of Bristol, and then continued that in a placement at AstraZeneca, where she studied motor neuron disease. She's been at University of Sheffield since 2021, where she's been doing her PhD, and she graduated earlier this year, earlier in 2025. She's currently working in Ivana Barbarish's lab where she's creating a new stem cell model for CMT2A, and that's what Lydia is going to talk to us about. So when you're ready, Lydia, please do your talk.
Thank you very much, John. Can I just check that everyone can hear me?
Yeah.
Yeah, amazing. Okay. So yeah, my name is Lydia. I am currently a researcher at the University of Sheffield, and I've been working on researching Charcot-Marie-Tooth Disease type 2A for the last 4 years now. So I'm just going to give you a little bit of a flavour of what we've been doing here in Sheffield, looking into this type of CMT. So my slides aren't moving. There we go. So just to give you an outline of my talk, I am going to introduce you all to stem cells and how we can use stem cells to understand Charcot-Marie-Tooth disease type 2A. And then by doing so, we can start to try and discover new drugs that might help those who are living with CMT2A. So what are stem cells? Stem cells made all of you. They are cells that are found in early embryos, or they can be created from skin or blood cells. And they are kind of like a blank canvas for human cells. They can be turned into any type of cell type. And this is really exciting for us researchers because it means we can take stem cells and turn them into any type of cell that we want to study, including motor neurons, which is great for me because these are the cells that are most impacted in CMT2A. So Charcot-Marie-Tooth disease, just to give us a better overview, it's the most common form of type 2 CMT, which Mary gave us a lovely introduction to, and it's caused by variation in a gene called mitofusin 2. And this gene, mitofusin 2, makes a protein called mitofusin 2, which is found on mitochondria, and mitochondria are the powerhouses of our cells. They give our cells all the energy that they need in order to function and survive. In those living with Charcot-Marie-Tooth disease type 2A, it mainly affects their movement and mobility, but there is often sensory pain too. But we predominantly think of this as more of a motor form of Charcot-Marie-Tooth disease. What's really important to note is that we do not know how variations in mitofusin 2 actually cause CMT2A, and consequently, we don't have any treatments for CMT2A, which is rubbish for those living with CMT2A. So consequently, we need researchers to be able to make CMT2A in a dish to be able to study CMT2A and therefore identify some possible treatments, which is exactly what I've done. So we've taken some stem cells and we've changed the DNA in these stem cells via gene editing using that CRISPR that Mary and John have been talking about. We can change the DNA in there to give them a common mitofusin 2 variation that's seen in people with CMT2A. And by doing so, we can have some healthy stem cells, which we see here, and we've got some CMT2A stem cells here. So each of these green dots is an individual cell, so they exist in these big clumps. And what's interesting to see is that when this mitofusin 2 variation is present, the stem cells are still pretty happy, which makes sense because you can still make an entire human out of CMT2A. People with CMT2A, the rest of their body forms very normally. It's just those motor neurons that seem to have a problem. And we can then go in and have a look at the DNA of these cells. And if you look at this yellow highlighted black bump here, we can see there's just the one peak, but when we look at our CMT2A stem cells, we can see there's a green peak and a black peak, and that means our mitofusin 2 variation is correctly in there. And now earlier I mentioned we can turn stem cells into any cells that you can find in the human body, which is exactly what we do. So we can turn stem cells into motor neurons, which are the cells that move your arms and legs. Very specifically, we make these motor neurons that can move your arms, and this takes around 34 days, and we're giving the cells lots of different chemical compounds over these days at different time points to guide the cells through that differentiation. So we can then make some lovely neurons, and you can see they've got tiny little cell bodies, which are in the white here, and they've got those really long spindly axons that are reaching out, and in the body these would be going down your arms and legs and reaching your muscles. What we're really interested in is looking at what's actually happening in these long, thin axons. So neurons are a really unique shape compared to other cell types. We often think of other cell types as just being these little circles, but neurons are very long and thin, and they are enormous. In the average human, your largest motor neuron is around 1 meter long, which is absolutely stonking in terms of cell sizes. So they have very unique demands in terms of energy. So those mitochondria I mentioned earlier, they have to move up and down the neuron in order to reach these ends. And if the mitochondria need to reach these ends in order for the neuron to be able to talk to the muscle correctly. We're very interested in how these mitochondria move, and we can actually record this in our cells. So here is one of these recordings. So these yellow dots are actually mitochondria, and we can see that they are moving backwards and forwards in this axon here. And this is in a neuron that's been made from healthy stem cells. But if we make a neuron from our CMT2A stem cells and record the mitochondria moving, what we actually see is that there is basically no movement. And I promise this is playing. What we see is the mitochondria just don't move. But because now that we have a difference between our healthy neurons and our CMT2A neurons, it means we can start to look for drugs that could potentially increase the mitochondria moving in our CMT2A neurons. And that's exactly what we've done. So we've tested licensed and unlicensed drugs on CMT2A neurons. And one of the exciting hits that we found is one for an HDAC6 inhibitor. So HDAC6 is an enzyme that alters the motorways of the neurons, so what the mitochondria are actually moving along. And by inhibiting this enzyme, we can reinforce the motorways of the neuron. So just as a reminder, here's what the CMT2A neuron and their mitochondria look like. But if we add our HDAC6 inhibitor, we start to see movement again. And this is more reminiscent of what our healthy neurons were looking like. And very excitingly, a company called Augustine Therapeutics, they started a phase 1 clinical trial back in May this year for an HDAC6 inhibitor, specifically for the treatment of multiple types of Charcot-Marie-Tooth disease. So I'm not sure when we can expect the results from this, but I know that the whole CMT community is really looking forward to seeing the results. Furthermore, now that we have our CMT2A in the dish, we can start to screen some different compounds as well, because more is more when it comes to available treatments. So this is actually work funded by Muscular Dystrophy UK and was underdone by our amazing postdoc, Dr. Rebecca Lee. And she screened loads of different compounds in our CMT2A in a dish. And she found some really interesting hits, which we are currently further validating to see if they really are capable of improving the mitochondrial movement in our CMT2A neurons. So just as a quick summary, we can use stem cells to make CMT2A in a dish. And with our CMT2A in a dish, we can see some clear differences between healthy neurons and our CMT2A neurons. And we can also improve our CMT2A neurons with drugs. And I hope I've also convinced you that there's some exciting research, CMT research happening in the UK that you might not have been aware of. So just a big thank you to everyone who has helped me and all of my colleagues and all of our funders as well.
Fantastic. Thank you very much, Lydia. Just to address a couple of the comments in the Q&A, thank you for the question about research in Serbia. I think we'll get back to you by email on that. It might be a bit specific and a little bit more complicated than we can answer right here. And the other question about the low-level laser, perhaps we'll put that off until the Living Well session. So thank you for that. So Lydia, really interesting technology, really exciting to see some of that microscopy, which is so convincing about these mitochondria that are not moving. The HDAC inhibitor that you're using, is this a drug that's used elsewhere? So would this be repurposing of an existing drug?
So the one that we use is not licensed to be used in humans. I don't think there are any that are licensed in humans at the moment. This one that's in phase 1 clinical trials by Augustine Therapeutics, this is the first in human use, but there's a lot of preclinical data to suggest that it's going to be not awful. I think we're all quite optimistic, but obviously we need to do these trials just to have any safety concerns addressed. But yeah, these inhibitors have been used in human cell models, in animal models, several CMT animal models, and they've shown really great efficacy.
Really interesting. And I suppose if that's not a licensed drug already, then that kind of extends the testing period. So I mean, I guess for your type of research, the next stage would be some animal models. Would the plan be now to try some of these HDAC, the HDAC6 inhibitor in a CMT model, or where would you be going next?
So we have actually already tested the HDAC6 inhibitor that we use in a zebrafish model, and this showed really great efficacy over the course of 3 months, where zebrafish who have a mitofusin 2 variation, we measured their swimming abilities over several months, and the CMT2A fish, they really struggle to swim because they're losing their motor function. But if you give them a HDAC6 inhibitor, you see no loss in their ability to swim over several months. I know other research groups have already used an HDAC6 inhibitor in CMT2A mice and rats as well, I think. They've also seen a rescue in that motor phenotype. In terms of what we're looking at, we are currently further validating the new compounds that we've uncovered that aren't HDAC6 inhibitors that can increase the mitochondrial movement. So we have more parameters that we can look at to assess the health of the neurons and the happiness of the neurons, which is what we're focusing on at the moment.
Excellent. And it looks like you've got more candidates coming through. So there's interesting work to do in the future. Thank you so much for your talk, Lydia.
Thank you.
There are no other questions. Oh, hang on a second, something's just come through. Do you know which types of CMT the latest HDAC6 trial could potentially cover, assuming it's for type 2?
Yes.
Are you able to answer that, Lydia?
I haven't looked very hard at the actual outline of the clinical trial, but off the top of my head, I think one of the press releases said it was for type 1 and type 2, but they didn't specify specific subtypes within type 1 and type 2. But my educated guess would be that any form of CMT where you get axonal death, this could potentially be useful for. I don't know if Mary's more across this than I am.
Yeah, thank you. They've tried it. The original animal models were 2A, 1A, and 2D cigars. They tried it. They've also shown its efficacy in chemotherapy-induced neuropathy to prevent it. So it's more than just genetic neuropathies. But I mean, obviously this all has to be looked at again. So the current trial is a phase 1 trial, it's just safety, and it is 1 and 2, not specified. What they'll do for phase 2 and 3 trials in terms of specifying, but I'm sure it will be 1A and 2A at a minimum, probably 2D as well. And it may be just across them. It may be just across different types. We just have to wait and see what the safety data is. As you say, the ones used in humans are completely new drugs. So it has to go through the very rigorous. It's already gone through the first stage of that, John. So it's now into the phase 1. So the phase 1 trials in humans in CMT have to be in patients with CMT rather than normal controls for a lot of them. So I think that's slightly different than phase 1 and many other drugs, because it has to be in the people that would get the drug. So it's a little bit different.
Excellent. Thank you very much. I think that's all the questions, and I feel it's kind of rolling towards the end of the research session. So thank you very much to both Mary and Lydia for your talks. And I'm going to hand back to my colleague Jackie now for the Living Well session. So thanks, everyone.
Thanks, John. So as John just mentioned, we'll now move on to discuss living with Charcot-Marie-Tooth disease. So I'd mentioned at the beginning of today's webinar, I'm Jackie Monroe and I'm Head of Regional Support, Outreach and Information at Muscular Dystrophy UK. So I'm delighted to welcome our other panellists today who will be joining Professor Reilly and Dr. Jestice. So we are being joined today by Dr. Brennan, Sheryl Chatfield, Sarah Durso, Dr. Vasantha Gowda and Anne Furby. So I'll invite each of the panellists to introduce themselves and to make a few remarks about their experience of Charcot-Marie-Tooth disease and to raise some key points about managing or living with the condition. So I'd also mentioned at the beginning of the seminar that we'll be covering as many questions as we can that have been submitted in advance, but we'll also be using the Q&A function, which you should be able to see at the bottom of your screen. So please type your question or comment and we'll feed them into the discussion. And any questions that we don't manage to cover today or we don't know the answers to, we'll seek to answer directly after this seminar. So Katie, I will just make you a co-host if that's okay, and I will come to you first so you can introduce yourself and share your slides.
So my name is Katie and I'm a local neurologist in the west of Scotland, so in a very different site and centre to Mary. And what I thought I would do, kind of give you a wee background of CMT from a slightly different perspective, from a Scottish perspective. So first off, can you see my slides?
We can, yep, they're not on full presentation mode, but yeah, that's you now.
So first off, you know, obviously what you get with Mary and a clinic like Mary is an all singing, all dancing, you know, amazing, superb service. In the rest of the UK, it's very different. Now, we're lucky in Glasgow in that we have 4 neuropathy consultants, but outside of Glasgow in Scotland, up until earlier this year, we didn't even have another consultant who was interested in nerve and muscle disease, and that was just recently appointed a new post in Edinburgh. And to set the scene as well, most UK neurologists are looking after about 100,000 cohort of people. So the number of potential patients per neurologist in the UK is actually much higher than in other countries. So that kind of might explain as to why waiting times are so long, just to get seen in the first place. But also, I just wanted to show you this kind of data as well that we've managed to gather from our wee clinic in the west of Scotland, which serves a population of about 2.5 million people. So with the current kind of expected prevalence of CMT being 1 in 2,500, we only have about 250, 260 patients, which is about a quarter of people out there. So first off, we're not seeing all of our CMT patients. Now, you could argue that not every CMT patient needs to be seen, because quite a lot of patients with hereditary neuropathy with liability to pressure palsies might come along once and get an explanation and not necessarily need that continued input. What I found interesting about our cohort was the fact that pain was so common, and I think that's what we consistently see in clinical practice. I'm not going to go through the ins and outs. Our diagnostic rate is pretty good, but probably because we're not seeing enough patients. Now, in Scotland, compared to the rest of the UK, our diagnostic testing is limited in that we typically check the 4 big hitters, the 4 most common causes of CMT, and then our panel after that only contains 52 genes, but we've already heard that there's actually more than 100 genes known to be cause of Charcot-Marie-Tooth. So we're not fully there with the panels that we can offer in Scotland compared to the rest of the UK. What's my clinical tuppence that I could share with you guys from the point of view of being a neurologist involved in CMT? Genetic diagnosis matters for lots of reasons. It informs people, it gives them clarity. It can also help very much clinically as well. I've had a few patients with unusual forms of CMT with perhaps extra symptoms and signs that were attributed to other conditions, such as even functional or psychological conditions. But actually, this was all part of the CMT process. And actually being able to give that kind of molecular genetic diagnosis, a lot of patients find really helpful. Others sometimes are just like, well, it's a gene, you can't do anything anyways. It can help inform family planning. So pre-implantation genetic treatment, which is a specialized form of IVF, is available for patients with CMT. In my experience, most patients don't take it up. I have a few women in their 20s with really severe hand involvement who are opting for pre-implantation genetic treatment so that the embryo at the stage of IVF that are not affected with CMT can then be used for IVF. I think as a doctor as well, it is important to consider additional causes of neuropathy. So always to be aware of diabetes, certain medications. Certainly in Glasgow, where I practice, where there's a fair amount of patients with come from perhaps maybe lower socioeconomic status and don't have those opportunities to learn about diet and are exposed to alcohol, and that can be a major factor when the clinical course changes very suddenly. The other thing I would mention as well with regards to diabetes, sometimes if we're very aggressively treating diabetes, which we are now with a lot of these new weight loss treatments, patients can develop a treatment-related neuropathy. So I will often say to my patients who have coexistent diabetes with CMT, just be careful now, don't go hell for ding dong with your diet, just do it nice and gentle, and improving their diabetic control. And as doctors, we shouldn't always assume that new neurological symptoms are due to CMT. So in Scotland, there's very high prevalence of central nervous system demyelination, or in other words, multiple sclerosis. So it is important to be aware of that. Access to physiotherapy, occupational therapy and orthotics is very important as well. And the way it's done locally in the west of Scotland, you're referred to your individual health boards, physio and rehab set of specialists. What I would say to patients with regards to orthotics is that there are lots of different types of orthotics out there, and what might not work for you. First, don't just chuck it in the wardrobe and forget about it. Phone back your orthotic specialist and say, right, have you got anything else that could work? Sometimes the less rigid splints, such as push acqui, can be more wearable for patients rather than the rigid ones that sometimes cut in. I think the importance of exercise and stretching is really important. I will often say to patients with regards to stretching, just do it when you're brushing your teeth in the morning and the evening, and that way you're not forgetting about it. And having exercise as being something normal to do, particularly if you have kids with CMT, if they see you exercising 2 or 3 times a week, then, and that's something that is sustainable. I mean, there have been various kind of small studies looking at kind of various exercise regimes, which are really not really sustainable. But interestingly, they do show improvement even in distal weakness. But I think having something that is maintainable on a long-term basis and then showing that example to your kids if your kids are affected. And then access to orthopedic intervention for feet and or hands when necessary. I suppose just trying to access orthopedic intervention from somebody who deals with feet and knows about CMT as well, and knowing that the evidence basis behind what specific intervention to do isn't really there. I'm coming back to diet again, just because dietary cause of neuropathy is very, very common, certainly in my neck of the woods. There's no specific diet. If somebody's telling you to follow a specific diet for CMT, that does not exist. But I think having a good diet where you're covering all food groups, and if you think you're behind at all, taking a food supplement, but then being careful not to overtake supplements. For example, vitamin B6 can be very high in energy drinks as well. The other thing I often say to the young patients as well, so in Glasgow, we've been seeing a fair amount of young people not drinking alcohol, but taking nitrous oxide instead. And so just proactively warning people, you could fall off a cliff with that, because that can actually cause a really severe form of sensory ataxia that is not always reversible. So I think having that kind of discussion with people is really quite important. And those are the main points I really wanted to cover.
Thank
Oh
you.
yeah, in fact, there was one last thing actually.
Yep.
I'll just share my screen. There is because we don't have patients always accessing specialists, okay, and not having a record of patients with CMT. There is this CMT register which is available via cmt.org.uk. And that allows us, which has been developed by Mary and Alex Roster, and this will allow us to really get a good idea on how many patients are out there in the UK, to make an argument, with regards to including people in clinical trials, but also to help make an argument for that subspecialization in other centres, not just in these big city hospitals. Thank you.
Thank you so much, Katie. And there was a couple of things you'd mentioned there around genetic diagnosis and pain management that I'll circle back to, because there were some questions around that. And I know you'd mentioned access to physiotherapy as well, so I'm sure that Sheryl and Sarah will elaborate on that a wee bit more too.
Yeah.
Dr. Gowda, I wonder if I could come to you next. So Katie, obviously that was a really great overview, and from an adult's perspective as well. Dr. Gowda, you're a paediatric consultant, so would you be happy to introduce yourself and just explain a bit about your role?
Thank you. I have to say, this is difficult going after Kathryn, because she's covered pretty much everything that should be covered. So I am a paediatric neuromuscular consultant at Evelina London Children's Hospital. We are a tertiary centre covering the south of Thames and all the way to the border in the southeast. We have about 600 neuromuscular patients, and I just looked at the database. It's probably not updated, but there are around 65 CMT patients under our care. There are about, I was going to say 4 consultants. There should have been 4. We haven't been able to appoint the 4th one, but kind of 3 full-time equivalent consultants looking after the patients. It has been a very interesting experience, sort of from the pediatric side. Sometimes we have the diagnosis in the parents, and they're concerned whether the child has it and want the tests done. And sometimes there are some symptoms, and the families believe this, this is CMT, and you find that it's probably related to joint hypermobility or something else. So it's not always clear when they are very young, especially if they're 2 or 3 and they've just started walking and, learning to do things. So many a times we kind of, sort of watch them over time. And as Mary said earlier, neurophysiology is helpful, but it's not a yes and no answer. So sometimes you need to sort of wait for things to evolve and become clearer. We also get caught because sometimes, someone says, oh, this is peripheral neuropathy, here you go, here's your patient. And then I've discovered that that patient actually has RSACs, which is a different condition with a demyelinating neuropathy. So not all neuropathies are CMTs, particularly in pediatrics. I also have to say we don't have a Mary Reilly at our center. So, but we do come across very rare gene mutations. And again, CMTs are rare, and there are rarer gene mutations in there. For example, I have a patient with HINT1 neuropathy and also KF1A neuropathy. So, and when you look at the literature out there, our patients may not be doing the same things as what's published. So you don't know whether whatever we are seeing is a part of it or something new. So again, we are waiting and watching and collating the data, and where necessary, publishing it. In general, our cohort, I was just looking at the slides before, reflect the same, similar distribution with the types, but, with a large majority with CMT1A, and there are some with MPZ and a couple with MFN2 and so on. In pediatrics, we are always asked, I know I have it, for my child at least I want a cure, do you have anything? And it's a very common thing, it's like, I don't care about me, but for my child, I want the treatment. However, so until now, we didn't have much to offer, but as we heard in the previous talks, there is so much hope. I know this is not directly related to CMT, but I just wanted to share my experience with a couple of things. We also look after children with spinal muscular atrophy and also Duchenne muscular dystrophy. And from 2017, with all of our patients of spinal muscular atrophy type 1, with like expected life of about 2 years, we have lost only one patient with all the new advances, the antisense oligonucleotide, such as the nusinersen and the gene therapy, Zolgensma, especially when given early, they're quite transformative. I mean, there are significant side effects, for which the patients need to be monitored with the gene replacement therapies and so on. But still, from where we were in 2015-16 to where we are now, the landscape has changed completely. And we also have a tiny bit of experience with HDAC inhibitors, because we recently started using givinostat for Duchenne muscular dystrophy, and the RW is always a bit different from the very not sterile, regimented clinical trial scenario, and you learn a lot more, particularly in the rare diseases. So, as a specialty, pediatric neuromuscular wasn't very positive many years ago, but now we have so many advanced therapies out there which have changed the lives of our patients dramatically. I'm hoping, we will be able to say the same for our CMT patients in the future.
Thank you so much, Dr. Gowda, and I completely agree. I've been with the charity for about 8.5 years now, and it's amazing to see actually how much progress has been made in that time. It's really kind of exciting times in the treatment space, so thank you so much. Anne, if I could come to you next. So really pleased to have Anne Furby joining us from a kind of lived experience perspective. Anne, are you happy to kind of introduce yourself?
I am, yeah. I'm Anne Furby. I am not a doctor, so I don't have any fancy scientific information for any of you. I do have CMT1A. I was diagnosed when I was around 5. It's very prominent in my family, so even before the diagnosis, I had symptoms. My family kind of knew what it was. Yeah, so I am 39 nearly now, and I've lived with it pretty much my whole life, I guess. Yeah, I'm happy to answer questions. I don't have too much to add. One thing that I would say is there's a lot of talk with CMT about preventative measures, preventing progression and everything, which is very important. It's very great. But especially for older people, sometimes it's inevitable. Like, you've progressed to a point that you're in pain, you're struggling, you can barely walk. So I use a wheelchair. I'm ambulatory, but I use a wheelchair full time now. And I always found that was, my doctors and my physios really tried to dissuade me from doing that. They wanted to see me walking for as long as possible. And off the back of that, I became extremely overweight. I developed a very bad drug habit because I was so depressed. I had no quality of life. And eventually I said to my partner, I need to use a wheelchair. I feel like I'm giving up. To which he said, you're going to be giving up if you don't use a wheelchair. Anyway, fast forward, I've been using a wheelchair now for 5 years. And honest to God, I wish I'd done it sooner. I've done the London Marathon in it. I've lost all of the weight. I stay active. I don't think you should use a wheelchair and actually use it as a way to give up. But I just want to say that if you feel like you are going down that route where you're struggling to just get about and lead a good life, use the mobility aid. Regardless of what your specialists are telling you, or you might have good specialists, I don't know. If you feel like you need to use the mobility aid, use it, because it will improve your quality of life. Like you can really excel if you just, you know, help yourself. Just help yourself a little bit. And yeah, that's all I have to say.
No, thank you so much, Anne, and we're so grateful to have you with us today. I think you have a really good perspective, because you can have that paediatric perspective and the adult perspective of living with CMT as well. And I think you make such a powerful point around mobility aids. I know that transition for people can be really difficult at times, but we hear that quite often, that once people have made that transition to using the mobility aids, they wish that they had kind of done that sooner.
Yeah, it's life-changing. Like, it really, yeah, honestly, I wish I'd done it when I was in my 20s instead of getting closer to my 40s, but there we go. Yeah, no, thank you so much for sharing that with us. So I'll just come to our last two panellists, if that's okay. So Sarah, if you don't mind introducing yourself and a bit about kind of your role in relation to CMT, and then I'll come to Sheryl as well.
Hi, thanks. So my name's Sarah, so I'm a paediatric physio at Sheffield Children's Hospital. So we are a mid-sized tertiary centre covering South Yorkshire and surrounding areas. So our role, and as a physio's role, quite a varied job, part of supporting children and young people with CMT, because the presentation can be so varied. So part of my role might be working with and supporting community physiotherapists with children that are more severely affected, but also then working with children that have very minimal symptoms and perhaps don't have community therapists. They might be younger, preschool or early infant school. And part of my role, I see, is trying to foster some good habits that hopefully will see them through into future lives. As some of the other speakers mentioned about exercise and activity, about helping that child find an activity that they really enjoy, that hopefully they will be able to continue and becomes part of their routine. As we know, exercise is so important in CMT, and not only as part of CMT, as a young child, you're still developing your brain, still developing your motor skills. So if we can try and enhance those skills at an early age with activities that child enjoys, we hope that will be taken forward. And in kind of to add comment with you, Anne, about using mobility aids as well, we do try and help children and young people access wheelchairs when they're needed. One of the things that we try and champion is using a wheelchair so that you have the energy, because we know fatigue can be such a pressing issue for people with CMT. So using a wheelchair for the activities that doesn't matter to the child or young person, that they're in the wheelchair, so they've got the energy to get out and walk for the things that are really important to them, if that's being with their friends or going to a club or being part of PE. So they might use a wheelchair to get to and from the lunch hole, but then they've got the energy to take part in PE with their peers. That can sometimes be a difficult challenge, working with wheelchair services to persuade them that is needed. But yes, it's I'd just like to second your thoughts on that, Anne.
Thanks so much, Sarah, and I'll come back to you in a wee while, because one of the questions we had was around kind of advice for schools in relation to kind of supporting children to take part in PE and kind of activity and things like that as well. So I'll come back to you on that one. Sheryl, if I can just come to you finally, if you don't mind just kind of explaining a bit about your role from an adult's perspective.
Yeah, thank you. So I'm Sheryl Chatfield, so I'm a clinical specialist physiotherapist, and I work in the adult neuromuscular service at St George's Hospital in London. So I run a clinic jointly with our neuromuscular care advisor, who is also an occupational therapist. And we tend to run this clinic, and we see people with CMT every 6 to 12 months, and it tends to be a sort of a holistic overview of their day-to-day activities. And so within that, we're looking at falls and balance, we're looking at their daily activities, looking at exercise, any assistive devices. We cover things such as orthotics, fatigue, and work as well. And so within that, we try and really push, sort of, as Anne was saying, and I completely agree with that, like quality of life and using what's needed, making referrals to orthotics as needed, just to be able to live well. I think my sort of key take home really is thinking about exercise, and exercise not just for CMT, but exercise to maintain your health overall. So we know that, you know, all adults should exercise and be healthy, and that should be a range of exercise such as aerobic exercise, strengthening exercise, and we're also thinking balance and stretches. So just ensuring and being active in whatever way that you can is always better than no activity.
Thank you very much, Sheryl. So there's quite a few questions in the chat, and Katie had mentioned earlier on, actually one of the questions we'd received in advance was around pain. So there's a question in the chat that I'll just open up to the panel, if anyone feels that they want to add anything, either from a kind of professional or personal perspective. But someone's asked about FX405 low-level laser, and would it help with symptoms and pain from CMT? Is it supposed to improve nerve function? So that's part of a question. Another part of the question that we got in advance was around how you approach pain management in CMT, particularly when it affects quality of life. I'm assuming it's kind of multifaceted, and actually I know it can have quite a significant impact on people's mental well-being as well. So I'll just open it up to anyone who wants to answer.
I'm happy to put my tuppence, and then Mary can say what she does. The FX thing, I would have to Google that. I don't know anything about it, to be honest. Don't know the mechanism of action. But what I do with patients with CMT with pain is I sit down and talk to them to find out what type of pain is it. Is it pain that I think is coming from a nerve? Is it muscle pain? Could they have, you know, coexistent muscle problems? Is it pain coming from joints? You know, I've had several patients require joint replacement therapy. Is it something like carpal tunnel syndrome that requires intervention? And is it something about posture as well? Because we did used to do a few combined clinics with a physiotherapist here, which was amazing because I actually got to see what you guys do. And actually patients, their whole posture was actually having a complete impact because of unequal load across joints. And it's just a few simple exercises, stretches, incorporation into the daily routine help with that. So I think taking a good history and then deciding on what's causing it. Is it musculoskeletal or is it truly neuropathic? And when it's neuropathic, you want to make sure there's nothing else that could be contributing to the neuropathy. Is there anything else that could be causing, you know, a small fiber neuropathy? And there's a list of genetic conditions. Mary talked about amyloid earlier. We've got quite a few, you know, a large population now of amyloidosis. You want to make sure you're not missing anything acquired, and diabetes being much more common. And then thinking about, well, what medications can we use, and looking at what medications the patient's on already, you know, and what age the patient is, because depending on what age the patient is, they might be more susceptible to the side effects of the typical neuropathic agents, which often cross the blood-brain barrier. So they can cause things like, you know, you're feeling more dozy and doolally and not even fit for driving. And people who are older and on multiple medications and have other diseases that are much more susceptible to those medications. Often I'll start with things that are topical. So topical kind of cooling creams like menthol or capsaicin. We can access capsaicin high dose patches through the pain clinic. When things are difficult, I do involve the pain clinic because they have with them this whole kind of artillery of psychology as well, because it can be very, very difficult to deal with such a high level of pain on a daily basis, and combining that with a peripheral neuropathy where, you know, you're having to plan where you're walking at any given time and the levels of fatigue are just massive. So that's kind of my approach. But it's going to be very difficult indeed to manage.
Thanks very much, Katie. Mary, do you want to?
Yeah, so I think it's very similar. I think it's a very tricky one because I think years ago people always thought there was no pain, no neuropathic pain with CMT. That's what they said, particularly with 1A. So that was a misnomer for a very long time. But I think the most important thing is working out the cause of the pain in the individual person, as Katie said. Now, I do a combined clinic with our physiotherapy consultant, Gowda, which I found incredibly helpful. So often patients have more than one pain. Actually, it's extremely rare for patients to have one pain. Now, there's some very specific types of CMT that have characteristic severe neuropathic pain, like the one I mentioned, the trial that we're doing at hereditary sensory neuropathy. And neuropathic pain is more common in X1 and 1B than another one. So there are specific types you're alerted that it's more common, first of all. So I think that's the other thing. Katie's completely right. You have to be very careful about any other causes. If people, I was about to say, I've done this carefully, if people become faddish about their diets and suddenly cut out all meat without having a good replacement, etc., you can get B12 deficiencies and stuff as well that can cause it. So I think there are issues in terms of that. But I think a lot of pain is multifactorial. I mean, I think sometimes I think the posture is a huge thing, particularly people that are in wheelchairs. We will get this severe side pain or pain in their tummy or something, and Gita will assess them, and it is the posture, it is the incorrect wheelchair, it's the incorrect whatever else. Or they're walking with their orthosis and they're getting secondary pain in their joints and in their back, etc. So I think working out the type of pain is very common. One thing I've learned over the years, which is a common pain, which maybe I hadn't appreciated years ago, as well as the joint pain, as well as the musculoskeletal pain, there's what I describe as denervation pain. So it's very common for people to get pain in muscles that are quite denervated, particularly if there's still some acute denervation going on, which often happens in the more severe forms of CMT. So they'll talk about walking and getting this deep ache in their muscles. And it's usually muscles that are very denervated. It's not that it's not musculoskeletal, but it's intrinsic to the muscle being damaged by denervation. So I think that's the other type of pain. The treatment, as Katie said, is very much multifactorial. And I think one of the difficulty things is it's not always just medication. It can be medication, and when needed, medication is very important. But I think patients generally throughout the UK and many places in the world is accessing the correct pain people. So it's great to say use the pain clinic, and I agree, Katie, but I know throughout the UK, getting into a pain clinic, the waiting lists are incredible. And sometimes people go to a pain clinic that really doesn't have experience in CMT. So it's kind of a more formulaic, whereas those pain clinics that have the combination of, both medication, the proper therapy, the learning to live with it if necessary, and the psychological management of pain, I think are really, really helpful. I think when children are younger, often pain is a description, they're growing and they have CMT. When older people, they get secondary complications. So, if you have very severe foot deformity, ankle arthritis, etc., with time. So I think there are musculoskeletal and problems, as Katie said, needing hip replacements, needing knee replacements, etc. There are issues that happen probably more so and are more difficult for the patients because they've already got a disability. So it requires a huge multidisciplinary approach. It's very difficult for patients sometimes to access the care because people just say, it's not neuropathic, it's not this. It's often you're told what it's not, rather than what it is. And it doesn't matter what your pain is due to, you still have to address it. So I think it's the whole combination. And I do have sympathy, huge sympathy and empathy for people not being able to always access the right. And often the therapists are a very good starting point. If you have a really good therapist assess you and work out what can be dealt with relatively simply, the correct orthosis or even the insoles, people with heel pain or plantar fasciitis can be revolutionized by someone getting their feet sorted out. So I think there's a huge spectrum of it. I would say the one message to patients is just persevere. If you're not getting the answers, you can always push. If you push hard enough, you get what you want, to get to see the right people to try to address it. And I think it'd be interesting to hear from a children's point of view what pain. I'd be very interested in that because from what Vasantha thinks.
Yeah. Yep, thanks very much. Mary, Vasantha, I wonder if we can come to you, just if there's anything that you want to add from a kind of paediatric perspective. I assume maybe around kind of medication and things like that, there's quite a big difference for children.
I have to confess, we don't use medications as much. Quite a lot of the times, there are two things here. We, as everyone has said so far, we advocate physical activities and regular stretches and so on. Quite a few times when they complain of pain, it could be, with excessive activity and not pacing because they're still young and they're not used to pacing themselves. So, that's easily addressed. But sometimes it's because they're developing contractures over time. And that's what's causing the pain at the time. So we have so far with the orthotics and the stretches and so on, we managed it that way rather than actually going for any medications. I have to confess, we probably see the milder end of the spectrum, except for a couple of patients who, and one of them was in a wheelchair by the age of 6 or 7. Most of my CMT1As are actually milder compared to what the adult cohort sees. So that's probably why we haven't had to use, sort of advise on pain relief as much.
Thanks, Vasantha. And I think pain's a topic that we could probably spend quite a lot of time unpacking because it covers so many different areas. But I'm aware there's lots of questions coming into the Q&A that I'll try and get through. And there was actually a question for you. So someone said they've recently been diagnosed with CMT on the back of their ankle collapsing at 55. They're struggling to get used to using walking aids, especially crutches. So they were asking what options worked and what works for you now. So I know that you'd obviously mentioned about that transition to using a wheelchair. So I don't know if there's anything that you want to add to that, Anne, and then maybe I'll come to kind of Sarah or Sheryl if there's anything that they would want to add from an adult and a peds perspective.
Honestly, I've done the crutches, I've done the walking sticks. I never really got on with them. There was a couple of times that I had quite a nasty fall trying to use crutches, and what happens is your arms are left up here and your legs kind of hit the floor and you can do all sorts of damage. When I'm indoors, I do a lot of like furniture walking, like I just hold on to things as I'm navigating. But honestly, I'm just a big advocate for the wheelchairs. The right wheelchair, I feel like if you can self-fund an active wheelchair, that is definitely the way to go. I feel like even with wheelchair services, they will offer you a fairly decent wheelchair if they do offer you a wheelchair at all. But even they can be a bit hit or miss in my experience. If you're really struggling with your crutches, really struggling with your walking sticks, then try a wheelchair. That is my advice. Try it. I mean, I was really ashamed to use one. Like, I felt really embarrassed. I felt like people would look at me, people would judge me, and honestly it's been the complete opposite experience that I've had. So yeah, that would be my advice.
Thank you.
Ambulatory, don't get into a wheelchair and stop moving completely. I go to CrossFit classes every day. Everything is adapted for me. I train in my wheelchair. Like, there's a lot of things you can do in your wheelchair, probably more so than you can do out of it, actually, if you go down that route.
Thank you very much, Anne. So Dr. Gowda's got her hand up, and then I'll come to Mary as well.
I just wanted to add a little bit from the pediatric perspective to the wheelchair business. I have to confess, in pediatrics, we do push children quite a bit to do as much as they can. We do proper nagging. It's not just for CMT; it's for most neuromuscular conditions. It's important to keep them walking for as long as they can, until they hit the puberty, their growth is finished, and they. To make sure that there's lesser chance of developing scoliosis and so on. So there is that. As I mentioned earlier, we don't have a lot of children on CMT needing wheelchair, except a few, who have a slightly different trajectory. But if they do have it, in general, it's for backup rather than main use and so on. But we hear from boys with DMD. We do push them to walk as much as possible. We get them to walk in CAFOs. We do all kinds of things. And eventually, they reach a stage where they can only use the wheelchair. So it's a different condition. But what we hear from the boys is suddenly they are zooming around in their power wheelchair, hanging out at the city center, doing things they shouldn't be doing, joining their friends and having fun in general. So it does offer them that freedom, not depending on anyone else. So there are positives to that. But in pediatrics, there are reasons for us pushing them to, walk as much as possible. That was all.
Thanks so much, Vasantha. And I know someone had mentioned at the beginning as well around fatigue management. I think the use of wheelchairs can play quite a huge role in fatigue management as well. Mary, I'll just come to you next.
Yeah, I thought I would comment on this. So I think it's important, if there's people listening in, that the vast majority of people with CMT do not need or use wheelchairs. I think it's important we're not given just one side of the message. I think Anne's story was absolutely the right thing for her to do, and I'm glad. I'm sorry it took so long for her, but I'm glad she has a better quality of life. And I certainly have patients like that. And some people, it's the other way around. They resist the transition. So you see someone, I had someone in clinic on Tuesday who is housebound. And, you know, if he had used a wheelchair, it would mean he'd get to places and then walk the bit he can walk to enjoy them, going to weddings, whatever else. But because he won't use a wheelchair at all, it means his family really can't take him anywhere. So I think there is a time. But I think, you know, with CMT and with CMT1A, there's a huge spectrum of severity. And the vast majority of my patients don't use wheelchairs with CMT1A. With some other forms, it is different, but with CMT1A, with many other forms. And I think it is really important the advice is individualized. Now, as Anne said, she felt she was being pushed not to look at certain options. That's wrong as well, but the advice is individualized. And many patients, I find that, you know, you really have to work out why they're not able to walk as well and what do they want. So one of the things is, do you want to be able to walk a mile, a half a mile? Do you want to be able to walk 10 miles? Do you want to be able to walk? Can you walk to your car? What is important for you? And what can we do to make that? And whether that's the appropriate surgery at the right time, the appropriate orthotics, the appropriate insoles, etc. And I think that's really important. So I think it's an individualized thing. In my experience, the vast majority of people don't use wheelchairs, particularly younger on. Some do. I think all options need to be open. But I think I think Anne's completely correct that if you're in a wheelchair, it doesn't mean you give up. It's a wheelchair to make you, you know, to give you more options and to keep your exercise going. But I think there's a lot of people who have benefited hugely from input from our therapists about how to, you know, exercise better, do the exercise right for them. I had one 17-year-old with CMTX, who was doing gymnastics. Now, that was a really challenging thing to do with CMT feet, because if you think of the way you put your feet. So, you know, very gently over a year, we chatted about it. And, you know, I thought I had been successful in my chat till he came back and he was doing breakdancing. So I think it is a matter of what's acceptable to people at different stages of their life as well. And there's certain things that are hard on your feet. For instance, it's unusual for us to be comfortable with people running on treadmills with most forms of CMT. But if they say they're doing an exercise bike or they're doing another thing where there's not the weight thing. So I think I feel very strongly it's an individualized to get people to live the life they want to live in whatever way they want to do it.
Thanks, Mary. I think you're absolutely right. It's a very unique journey for people as well, and with support from a kind of multidisciplinary team. So, Katie, I'll come to you next, but I just also wonder if Sheryl and Sarah have anything to add around how you would support people to kind of explore what options might be available to them. And actually, I know we don't have anyone from occupational therapy with us today, but if there's a kind of role there as well. I'll just come to Katie next, and then I'll hand over to Sheryl and Sarah.
Thank you. I was just basically echoing what Mary was saying, in that very few of our patients in Scotland also need a wheelchair, but obviously it's individualised. And Anne, I mean, I think it's amazing that you go to CrossFit so often, but a lot of my patients, their only form of exercise is walking. And no matter how much we chat to them and get them to see physiotherapists, they see the physical exertion of walking as being their exercise. And I guess if you lose that and you combine that with the deconditioning that happens with age anyways, I would worry that there might be an accelerated, loss of mobility and resilience. That's my tuppence.
Thanks, Katie. Sheryl, is there anything that you want to add just in terms of how you might support people to explore those options? And then I'll come to Sarah as well.
Yes, of course. So sometimes crutches can be very difficult because of hand function as well. So sometimes we do find that crutches can be really difficult to use. So sometimes things such as walking poles are easier to use. That you can hold them in a slightly different way. They often give you more postural support as well than crutches, because crutches really do alter your posture as well. So sometimes it's just small changes like that, and think about as Mary and Katie and everyone have said that, it's think about the whole person. So it's thinking about hands as well as feet and legs, and is it a combination of using the orthotics and a different type of walking aid that might help? And it might be that you use a different type of orthotic in the home that you do outside, or it might be that you only use something when you're going for longer distances. So it is very individualized, but yeah, so I think I just wanted to bring in that we don't forget about the hands as well, because obviously with walking aids, you have to hold the walking aid. So that's really important too.
Thanks, Sheryl. Sarah, is there anything that you want to add from a kind of paediatric perspective? I just wonder as well, because I know Vasantha had mentioned around kind of encouraging children. But I know sometimes it can be tricky to navigate in the school space sometimes if there's a risk of falls and things like that as well. So I just wondered if there's anything you wanted to add.
Yeah, I think Sheryl, I thought the same when the gentleman asked a question about crutches. I wondered about how easy they are to hold, and there are different grips available. I would say I don't think I know of any children in our caseload that use a walking aid. For the children that I'm working with at the moment, we're much more advocating about how they perhaps plan their journey, having rest, so to sit down, you know, pacing a little bit more that way, rather than any children requiring using crutches or sticks or anything like that. So I don't have much experience in that in paediatrics. In schools and managing schools, I think there just needs to be the education into schools where possible. There are some nice resources. CMT UK have got information, CMT org as well also have information for schools and why exercise is important in CMT, and just normally having that conversation with the SENCO and discussing any risks that they might be concerned about is normally enough. Things that can be put into place, like leaving class slightly earlier, so you're avoiding the rush of everyone on the corridors and everyone on the stairs, and perhaps a lift pass as well for those bigger schools. Often schools are really happy to put those things in place, and then actually they might not even be needed, but they are there as a backup. But if parents are able to meet early with schools to discuss what some of the symptoms of CMT might be, because it's not always immediately obvious, can be really helpful in kind of bridging any concerns and helping ensure that child is still really active. I don't think falls in children are as big an issue as they are becoming adults. That might be a little bit because children do fall more, especially the younger children, so perhaps it just comes across as slightly more acceptable, but I don't think it's as big an issue as it is in the older population.
Thanks, Sarah. So I'm just going to move on, if that's okay. So Katie, you'd mentioned at the beginning around kind of genetic diagnosis and kind of getting a diagnosis, and actually one of the questions that we had submitted earlier on was around kind of family members getting a diagnosis as well. So someone had got in touch to say that they were advised a number of years ago that anyone in the family who is affected by CMT who requests genetic testing should be able to access it, as costs around this have reduced. But more recently they were given different advice, and because of nerve conduction test results, further blood tests weren't feasible. So their question is, why might that have changed? Has that changed? And actually, could that just differ between kind of country and health board and trusts and things like that?
I suppose without knowing but the specifics of the case, it's difficult to comment directly. But certainly, when a genetic diagnosis of any neuromuscular disorder is made, as a neurologist, we would refer that patient on to clinical genetics, who will meet the patient either face-to-face or by video, and will give them the opportunity for cascade testing. So cascade testing means testing of family members who are adults or symptomatic children, if they wish to be tested. And I suppose that the classical one to think of is this TTR amyloidosis, where people didn't come forward at all because there were no treatments. But as we've heard from Mary earlier, there are treatments now, and these patients are now coming forward very much through the clinical genetics clinic. With children, it's a bit more difficult. We don't tend to routinely test children because it's a genetic diagnosis. That should really be a decision that the child makes when they're able to kind of understand the impact of that, unless they're symptomatic, so unless they require treatment. So if somebody's had completely normal nerve conduction studies, that makes it very unlikely that we're dealing with an inherited neuropathy. Now, there's a caveat there in that some of the distal hereditary motor neuropathies can actually have normal nerve conduction studies, but it's their EMG that's abnormal, that you see the denervation. So has the EMG been done to the extent that you would want it to be done? Because the more muscles you test, the more likely you are to see something. But clinically, if there are no features, when you examine the patient of a neuropathy and the nerve conduction studies are normal, it's very unlikely to be a genetic neuropathy. Often, we'll see almost like the inverse of you'll see nerve conduction studies being very, very abnormal, but a patient can walk in the door no bother. Well, not no bother, but quite easily. So that if you saw that in somebody with an acute story, a patient with the kind of changes that we see, particularly in the demyelinated neuropathies, these patients are bedbound. So when there's a kind of a lack of concordance between what you're seeing in the neurophysiology being very, very severe, often that brings to mind you're dealing with an hereditary neuropathy. So it's very unusual to kind of be looking for the changes in the nerve conduction studies if you're thinking you're dealing with a genetic neuropathy, with that slight caveat being the distal hereditary motor neuropathies when it can be a bit more subtle. But what do you think, Mary?
I agree, obviously, to most of the extent. So I think there's two different scenarios here, and I think this is where the mix-up comes sometimes with patients being told things. So it's totally different for CMT1A and the rest of CMT. So CMT1A, there is abnormalities in the electrical studies at birth. So sure, this is years ago, not done here and out there. There was a Spanish study showing at birth, babies already have abnormal electrical studies. And by, 1 or 2 years of age, they're clearly abnormal. So if you have normal electrical studies and your family has CMT1A, you cannot have CMT1A. It is impossible. So that may be a scenario where someone is told there's no point in doing genetic testing. And other rarer forms of CMT1, we're not so sure that it can look normal and then become abnormal with time. So that doesn't apply to that. So that's a pure CMT1A. One of the issues in many of the axonal forms, more commonly, but also in some of the demyelinated, but many of the axonal late onset. That means they may be onset 40s, 50s, 60s, 70s. So have a normal electrical test in your 40s or 50s. If the disease is late onset in your family, if it's axonal, does not mean you don't have a risk of being a genetic neuropathy. So I think that's one of the issues. Telling people they don't have it is more difficult. And then, as Katie said, if someone comes to me like that, I've examined them, I find nothing, I would then refer them to genetics to discuss for predictive testing. So do they want to know that they carry a gene which has a chance of them becoming affected? But that's called predictive testing, which is different than diagnostic testing. But that is such a big problem that I won't, if I'm doing big family studies, I will not accept an unaffected adult with an axonal neuropathy as being unaffected for a genetic study, because I can't confidently say they don't have it. We're looking for new genes. So I think it is very different with CMT1A and with the rest of it. But I think, as Katie said, one of the things that's very striking is if you have someone that comes to you and the electrical studies can tell you this is a very long-standing problem. So they say they have no problems feeling, and you found absent sensory action potentials everywhere. It's very likely to be genetic. So there's ways we can look at it the other way around. But I think it is important for people with a later onset, which is a lot of the axonal types, to realize the electrical test, the clinical examination can be normal. And actually in CMT2A, which we heard about earlier from Lydia, the commonest type of CMT2 due to myelofussion mutations, it's well known that clinical examination is more sensitive than electrical studies for the very early part of the disease. So again, it's nuanced with the particular gene in the particular area. And most, and I think it is true actually in the UK, and I think it's an interesting point. It'd be interesting in the pediatrics view of this as well. And I don't know what age Anne had her diagnosis. She may have an opinion on this. But parents will come and say, I want to have all my children tested. I've got 1A, they're 1, 2, 6, 7, 8, I want them all tested. And the traditional advice in the UK is generally not to test anyone before the age of 18 unless they have symptoms, and then they can make up their own mind, which is pretty sensible. But then you'll have an adult saying to you, if I had known I had 1A and I was going to get this deformity, I might have, liked my mother or father, let's not be sexist here, to have done different kind of exercise or pushed me more in exercises. So I do find my pediatric colleagues do the testing in situations that I mightn't have. And I wonder if this is not as black and white as we might think it is. I'd be interested in what Vasantha thinks about that. And I'd be interested when Anne actually got her diagnosis genetically. Thanks.
Vasantha, do you want to?
Yes. So that is so true. I started off like that, Mary. I have to say, if they are not symptomatic at all, they shouldn't be tested until 18, etc., etc. But over the years, I think they've all changed our practice. I'm not just talking about myself. I've seen my colleagues do this as well. That there are occasions when we have tested them, because of situations described. I have a question for the adults here. Adult neurologists. Our geneticist, clinical genetics, sort of a team member asked me about PGD for a family with HNPP. In general, we usually don't get asked about PGD in CMT, at least, in the pediatric side. Whether or not they have been discussing this with their own consultants on the adult side, I don't know. But, when there are just children, we're not discussing that. So is this something that is being routinely offered, or offered when,
I think it is. Katie said she has it rarely. I would say we've quite a number of patients that do it. I think it's an informed choice for the patient. Most forms of HNPP, I've never been asked, I have to say. And most forms of CMT are allowed, they've been through the process, but if it's a novel form with a novel gene, you have to get permission for that. And also, one of the really difficult problems for us as consultants is proving that variant is causing the disease. There's a certain level of proof you need to know. But it is something, I've had it across CMT, across 1A, multiple other forms of CMT, 2A, etc. Initially, I was quite surprised to be asked for CMT 1A, but actually, CMT 1A is a very high morbidity. So, I have a patient who's had 17 operations on their feet, and that's not there are records out there. So each operation, can take you 6 months. It's not the usual. When people say it takes, I'm sure the therapists know this, it takes so long. So I think it's an individual. So I think there'll be a patient in clinic who has a very severe form of CMT and say, I have a great quality of life, I'm happy to have children. And there'll be a patient who seems to us to have mild CMT, but for them it's a huge problem and we choose not to have children. So we do get asked for it multiple times a year for different forms of CMT. And I think it's I'm very non-directive. In counselling, you have to be very non-directive in this, but it is something that's asked probably more as time goes on rather than less, I think. Until we have treatments, I think that will continue.
Thank you.
But not HNPP. I've never been asked for HNPP, but that's often because the diagnosis is made, later on, or it's not,
Yeah.
Thank you. And Anne, I think you had mentioned when you were chatting earlier on that you were 5 when you received a diagnosis. If you're comfortable sharing, if you're happy to, is there anything that you want to add to that?
No, I don't actually have any recollection of ever being diagnosed. Whether that was because I was too young, I've blocked the memory, I don't know. My memory starts from having AFOs cast from my feet, hating them, having to wear the orthopedic boots, hating them, having to go through this whole phase of having my leg plaster casted for a period of 6 weeks and having it changed every week to act as like a permanent splint that I couldn't take off. I actually only got a diagnosis around about 3 years ago at Queen's Square as a routine kind of checkup with my specialist there. So yeah, I don't remember being diagnosed, but I know that my family just knew, like there probably was a diagnosis, but yeah, I don't remember it.
Thanks, Anne. So there's lots of questions that I haven't got round to going through yet. What I would say is if we don't get round to answering them today, feel free to either email them in to us and we'll do our best to answer after today. So we had a question in the chat about, so Mary, I think you might have touched on this during your presentation, but how many known variations, including subtypes, are there of CMT?
Right, well, there's about 135 genes, and with the word about is because literally it'll be out of date yesterday from today, and there's ones we know ourselves in the research area that haven't been published yet. So that's the number of genes. Now, in certain genes, like JGB1 that causes X-linked CMT, there's 456 different variations in the gene. So that's variations within a gene. So if you multiply 130 by that, there are thousands of different variations. So one of the issues is some of the really rare variations are in an individual family or in very few families. And that is the ones that are trickier sometimes to say if they're causing the disease. So there's multiple genes and even more variations within the genes. And our ability, you know, the percentage, the 23% or so of people that we don't have a diagnosis, technologically that's getting easier. Mostly is due to the fact that there were parts of the genome we couldn't see. We now have new technologies, things called long read, etc., that are able to do that. I have to say, you know, and I know it's slightly different in Scotland. I'll say this before Katie starts shouting at me. I have to say, in the UK, you know, it's fair to say we're leaders in the world of genetic diagnosis. So, you know, if you go into the UK anywhere now, you'll get a whole genome sequencing panel for your CMT. And we and our experts input into that panel and can update it with genes that go through an intuitory panel and get put on it if they're real. So it's kept very up to date. If you're in the US, your diagnosis depends on whether you're insured to have a particular panel done. And the companies offer panels. It's not like some of them do whole genome, some of them don't. So you don't know if you've been tested for, like the SOAR gene that came out. We know there are people that haven't been tested for it because of the way they were tested. So I think the UK, for this, in terms of, there may be things people say about it, but in terms of diagnosis, I think it's leading in the genetic diagnosis, being extraordinary. The 100,000 Genome Project and the follow-on from that has been extraordinary, actually, in terms of what it's delivered, compared to almost anywhere else, actually, I think, which is why we have the highest diagnostic rate in the world, actually, for CMT.
Thanks, Mary. And I know we've only got 10 minutes left, but we did have a couple of questions around respiratory involvement in CMT, and I know that we don't have any respiratory colleagues with us today, so we may not be able to answer in any great detail, but I just wanted to kind of touch on these. So I suppose, so one of the questions we had around, is there a particular type of ventilation machine that's recommended for breathing difficulties associated with CMT? You know, in my time with the charity, I've actually not come across breathing difficulties associated with CMT very often. So I wonder even if we could just touch on how, you know, how often that comes up actually, and is that associated with a specific type of CMT?
Maybe I can start and then Katie. So they say that's a really important question. So that's the first of all, a really important question. So in straightforward CMT1A, we say straightforward because of the one we know most about. It clearly isn't straightforward. I'll have Anne looking at me. So basically, there is a higher instance of obstructive sleep apnea and sleep apnea. So even in the what we don't think that is commonly associated. So you can have sleep apnea more commonly. Now, clearly, there are other reasons for sleep apnea in patients if you're very overweight. So I have patients who are very overweight with CMT and have sleep apnea, and you'd hope that would help them get the treatment they need for the being overweight, but there's fairly restricted rules on that yet. In certain forms of CMT, it's much more common. So in a form of CMT called CMT4C, TRPV4 variants, you can have vocal forward involvement and you can have diaphragm involvement as part of it. With certain recessive mutations like GDAP1, it doesn't really matter the names, we know you can have early respiratory involvement. So it's individualized to the gene, the risk of it, but all patients with CMT should be monitored. So I routinely, all my patients that come to clinic with any type of CMT get asked about how they sleep, how they feel in the morning, do they feel fatigued when they wake up, which I always find a weird question because I don't remember not feeling fatigued because that's because I don't sleep enough. So it's one of those things you have to ask everyone about. That's very important. And we have a very low threshold for doing a sleep study if needed. There's no specific machine for a particular type of CMT. It depends on your individual problem and what machine or what type suits you best. But it is, I think, if people do have a problem with their breathing, particularly sleep apnea due to CMT, it can revolutionize their lives by having that treated, because fatigue is a problem already, but fatigue is a huge symptom of sleep apnea. And I've seen patients who've literally, been revolutionized by having the appropriate treatment. So I think it's really important. Everyone treating CMT needs to be aware of it, particularly adults, but some of the severe forms in children, we have people on particularly nighttime ventilation with CMT, occasionally some help during the day as well. So I think it's a really important question.
Thanks, Mary.
I would back that up as well. I think patients are not going to volunteer a poor sleep history to you, and it's seen in a variety of our neuromuscular conditions. So you have to ask questions, and there actually is an online calculator for what's called the Epworth sleep score that you could even do yourself. And if that's above a certain number, that should direct a straight referral to a sleep clinic. One thing I would mention is that the waiting times for these sleep clinics are astronomical at the moment. My last patient with CMT I referred took over an hour, not an hour, a year to be seen. And this particular patient had a huge amount of upper body lipodystrophy, and clearly was having issues with sleep apnea. And despite me trying to escalate it, it took still over a year to get seen. So it can in Scotland, yes. So yes, things in Scotland are a bit rubbish compared to down south for.
I think it varies in different places. I think we have a very quick thing, but I think it varies. I think this is where the benefit of being part of the neuromuscular community, because I think a lot of the muscle disease, particularly the pediatric ones, are very good setups. So I think if people are tied into that, sometimes the access is much better and quicker. So I suspect pediatrics are much quicker at doing this because with the Duchenne's and with the spinal muscular atrophy, etc., particularly Duchenne's. But I think that's where I think in parts of the country where there's a good neuromuscular service, that actually can be quicker than trying to go through normal sleep. But I appreciate in Scotland has got different bits to it as well, isn't it?
There's different bits, and we have like a motor neuron disease ventilation clinic in one hospital, and it kind of depends what hospital you're referring from as well. So yeah, it can be difficult.
Thanks. Thank you both. And there was just one final question that I wanted to touch on in relation to respiratory as well. So someone had got in touch with us to say, could you address tracheostomies and CMT4C? So this person's used VPAP for 20 years and is now being suggested a tracheostomy while they're well enough. But there seems to be kind of little experience around this procedure in people with CMT, or kind of understanding of living with it might involve afterwards. So I suppose if there's anything to add to that question.
So it is one of the forms of CMT we occasionally see tracheostomy and 4C because of the vocal cord problems as much as the breathing to do with it. I think we can comment on some individual circumstances. But I think, that is a form of CMT, and there's probably going to be a drug trial in that form of CMT. There is a company called ActioBio who've developed in collaboration with Johns Hopkins researchers, have developed a drug which looks like it's very promising preclinical work, and it's being planned to try to go into phase 1 fairly soon. But I think so there is a lot of experience with managing the vocal cords and managing the breathing in that. So I think it is, if somebody has that and that's been recommended, in the end of the day, if they're under a good clinic, it's not whether it's a structural issue. If your breathing apparatus and your vocal cords are not working properly, the fact that you've CMT doesn't change what you need to have done for those. You know what I mean? So I think there's nothing special about it. It's just that it's more common. But it's very important to listen to to ask what, if people think you need one, you can always ask for a second opinion if you feel that you're not comfortable with the advice. But I think it is something you need to ask about why you need it, what would happen if you didn't have it, what are the risks of each, and then it's a very, very individualized. But yes, it is a form of CMT. We do see this happening on occasions. Most people not, but we certainly do see it on occasions. And managing the vocal cords, there's all kinds of other things that can be done with vocal cords. Again, that's very specialized ENT involvement in that.
Thanks, Mary. And I suppose that there's probably a role for connecting with other people who have been through that procedure as well, if it is.
No, I think that's very important for lots of things in CMT, and the people, how they've adjusted to various things, and it is very important to do that. Brilliant. And it's something we're maybe not as good at because we're always so paranoid about confidentiality that we say nothing unless we have all kinds of permissions, because we have to be really careful about it. But often patients are very happy to speak to another patient if the right permissions are in place. But we have to be very, very careful about that as well.
Yeah, thank you very much. So we're very nearly at the end. It's been a really great session. There was just one question that I think is really important to end on, and apologies because I know there's lots of questions that we never managed to get through today. I did think we would have lots of discussion during this webinar, so please do email us in on our info@musculardystrophyuk.org email address, and we'll do our best to get back to you after the webinar. But someone's asked, how do you get on the CMT webinar register? Sorry. So Katie and Mary, I know you both kind of touched on
I'll
that.
This is Mary's baby.
Yeah,
it is my baby, but actually it's a patient's baby. So we set up the register here about 2 years ago from a patient donation. So if that person is out there, and I know I'm due to talk to you soon, thank you so much, because it was really difficult to get funded. So the original, and we set it up on purpose that it's a patient entry portal. So patients enter their details, and then we can approach their clinicians to get more details on it. And so it was funded originally by this patient. Then the CMT UK have funded it. And now, as part of the MD UK Transform CMT and continuing funding for CMT UK, we have funding now for the next 4 years to run this. Anywhere in the CMT, and actually I will send the link to you. So we run the register here, but we have the access to it through the CMT UK, so it's easy for patients to remember it. And we're happy to send out the link to everyone. But we love people with CMT to register. It's really easy to do. You have to put in minimal information, but we really need to understand the landscape of CMT and to understand throughout the UK. And one of the things we'll be doing is looking at the health economic issues of this. That might sound like a weird thing to do, but if you want to ever get a drug licensed, you need to have that information in advance.
Thank you. Thank you so much, Mary. So that brings us to the end of today's session. So I'd just really like to thank all of our speakers for sharing their time and expertise, and a huge thank you to all the attendees for your questions and comments and the engagement throughout the session. So the recording of this webinar, along with others, will be available on our YouTube channel and on our website. We'll also be sending out a very brief feedback survey, and we'd really appreciate you taking a moment to complete it, as it helps us to plan and improve our future sessions. And just a reminder, while today's session provides valuable information, it doesn't replace advice from your own healthcare team. So if you do have specific concerns or questions about your health or your care, we encourage you to speak with your neuromuscular specialist or your clinical team. So thank you again for joining us today. Thank you to all our panellists. We hope you found it useful and informative. Thank you very much, everyone.